Poliomyelitis. Objectives. At the end of the presentation, the learner would be able to define poliomyelitis, enlist clinical features, describe etiology of poliomyelitis, explain epidemiology, pathogenesis and pathology of poliomyelitis, discuss clinical manifestations, describe diagnosis of poliomyelitis, illustrate treatment and prevention of polio, explain nursing management. Definition. Poliomyelitis is highly contagious acute infectious disease caused by poliovirus. It is an acute viral infection. It is primarily an infection of the human alimentary tract, but the virus may infect the central nervous system in a very small percentage, 0.5%, of cases, resulting in varying degree of paralysis and possibly death. Community Medicine, 10th edition, Dr. Mohammed Naveed Alam. Clinical features. Fever, sore throat, muscle pain, paralysis. Etiology. Causative agent, poliovirus. Family Picornavairidae, genus Enterovirus. Single strain RNA. Resistance, sensitive to heat, oxidant. Ultraviolet rays. Etiology. Serotype. On the basis of neutralization tests. Type I. Type 2. Type 3. No cross-immunity. Epidemiology. Source of infection. Patients and carriers. Inapparent inf. And non-paralytic inf. Route of transmission. Airborne, respiratory tract. Fecal-oral route. Epidemiology. Susceptibility. Universal susceptible to polio. Covert infection 90%. Paralytic patients 1%. Lifelong immunity to same type virus. Epidemiologic features. Children under 5 years, 6 meters / 5 years. Summer and fall. Pathogenesis. Pathology. Place of lesion. All of CNS. Spinal cord, brain stem. Motor neurons in anterior horns of cervical and lumbar, enlargement of spinal cord. Pathology. Pathologic features. Neuron necrosis. Inflammatory infiltrate of leukocyte, lymphocyte. Clinical manifestation. Incubation period, 5-14 days. Clinical types. Covert infection, 90%. Abortive poliomyelitis, 4-8%. Non-paralytic poliomyelitis. Paralytic poliomyelitis, 1%-2%. Clinical manifestation. Paralytic poliomyelitis. Prodromal period. Propralytic period. Paralytic period. Convalescent period. Sequela period. Clinical manifestation. Prodromal period, 1-4D. Upper respiratory tract infection. Fever, fatigue, sore throat, headache. Intestinal tract infection. Vomiting, diarrhea, constipation. Abortive poliomyelitis. Clinical manifestation. Propralytic period. Progressing this phase without prodromal phase. 1-6 days after symptoms of prodromal phase. Without prodromal phase. Clinical manifestation. Propralytic period. Fever, 2 hump fever 10-30%. Symptoms and signs of CNS. Severe headache and vomiting. Dysphoria or lethargy. Muscle pain. Clinical manifestation. Propralytic period. Symptoms and signs of CNS. Cutaneous hyperesthesia. Hyperhidrosis. Meningeal irritations, neck stiffness, Kernig's and Brudzinski's signs positive, 3-6D, non-paralytic poliomyelitis. Clinical manifestation. Paralytic period. Paralysis types. Spinal type. Brainstem type. Mixed type. Brain type. Clinical manifestation. Paralytic period. Spinal type, most common. Paralysis features: flaccid, hypomyotonia, tendon reflexes are weak or absent. Asymmetric distribution. Without sensory loss. Clinical manifestation: paralytic period. Spinal type, most common. Paralysis muscles. Paralysis of extremities, leg, arm, proximal distal. Paralysis of diaphragmatic and intercostal muscles affects respiratory movement. Paralysis of abdominal muscle, stubborn constipation. Clinical manifestation: paralytic period. Brainstem type. Cranial nerve paralysis, 7 and 10, then 9 and 12. Facial paresis. Dysphagia, high-pitched voice. Respiratory center paralysis. Central respiratory failure. Cacrhythmic breathing act. Vasomotor center paralysis. Clinical manifestation: paralytic period. Brain type, polioencephalitis. High fever, convulsion. Disturbance of consciousness. Tonic paralysis. Mixed type. Spinal type plus brainstem type. Clinical manifestation: convalescent period. Paralytic muscles begin to recover. Distal proximal. At first 3-4 month quick recovery, 6 month later recovery slowly, the recovery process reaches its limit around 18 months. Clinical manifestation: sequela period. Persistent paralysis. Muscular atrophies. Deformities of limbs. Laboratory findings: cerebrospinal fluid. Aseptic meningitis. Pleocytosis, 5500 × 109/L. Protein, normal or slightly increase. Albuminous etiologic dissociation. Glucose and chloride, normal. Virus isolation, pharynx, feces, blood or CSF, brain. Laboratory findings: serological test. Specific HIM-AB, blood and CSF. Neutralized AB. Complement combining AB. 4-fold rise. Diagnosis. Epidemiological data. Clinical manifestation: laboratory findings. Abortive or non-paralytic polio, isolation of virus or serological test. Paralytic polio, clinical diagnosis. Differential diagnosis. Guillain-Barré syndrome. Symmetric, ascending paralysis with loss of sensation. CSF, protein elevate with absent or minimal pleocytosis. Albuminous etiologic dissociation. Rapid and complete recovery. Coxsackie or echo, no epidemic, no sequela. Differential diagnosis. Paralysis caused by other enterovirus. Coxsackie or echo viruses. No epidemic, no sequelae. Medical treatment: prodromal and preparalytic polio. Isolation and rest in bed. Not accept muscular injection and operation. Hot moist pack to muscles. 50% GS and Vit Quantilda 2 grams for IFN. Hydrocortisone. Treatment: paralytic period. Limb paralysis. Nursing for paralytic limbs. Put the limbs on function position. Vit CATP of drop. Galanthamin or prostaglandin. Treatment: treatment for respiratory obstacle. Bulbar paralysis. Dysphagia. Keep airway clear, sputum aspiration, postural drainage. Tracheal intubation. Tracheotomy tank respirator. Treatment: treatment for respiratory obstacle. Respiratory center paralysis. Respiratory stimulant. Tracheotomy tank respirator. Respiratory muscle paralysis. Mild observation. Tank respirator. Treatment: convalescent and sequela period. Acupuncture. Massage. Prevention. Control of source of infection. Isolation, 40 days after the onset of illness. Protection of susceptible population. Attenuated live vaccine by oral. Killed virus vaccine. Nursing management. 1. Complete bed rest. 2. Physiotherapy may be necessary. 3. Place the child on firm mattress with support for feet, change position frequently. 4. Moist heat application to decrease muscular pain. 5. Encourage oral intake of food and fluid. 6. Catheterization of distended bladder may be necessary. Cont. 7. Antibacterial prophylaxis may be ordered. 8. Good disposal of stool because it is infectious. 9. In bulbar poliotherapy is directed at suctioning of pharynx, postural drainage, IV fluid, tracheostomy, oxygen, respirator. 10. Prolonged rehabilitation may be necessary including braces, splint or surgery. Summary. Outbreaks can still occur in the developed world, usually in groups of people who have not been vaccinated. Polio often occurs after someone travels to a region where there has been an outbreak of disease. As a result of a massive, global vaccination campaign over the past 20 years, polio exists only in a few countries in Africa and Asia. References. Nancy T. Hatfield, 2008 7th edition. Pediatrics Nursing. China. Prul Data, 2007 1st edition, Pediatrics Nursing. New Delhi, India. M.J. Robinson, 2007 5th edition. Practical Pediatrics. Melbourne, Australia. Stephen R. Bloom, 2011 5th edition. TUI S. Medicine. London. Vanton. H. et al. 2010. Part 12, Cardiac Arrest in Special Situations, 2010 American Heart Association Guidelines for Cardiopulmonary Resuscitation and Emergency Cardiovascular Care. Mid 20,956,228.